All right, so scoliosis radiography. Typical scoliosis exams may include PA or AP upright, PA or AP lateral, bending views, lateral upright with or without bending, and then PA or AP recumbent. So what we're trying to do is we're trying to demonstrate if there is any scoliosis, and then sometimes the amount or degree of curvature that occurs with force of gravity acting on the body. So you're always going to do them in an erect position. So imaging PA or AP, what we've got to keep in mind is we're usually imaging this on young adults. So if they're female patients, what we want to keep in mind is dose to breast tissue and as well as dose to reproductive organs, okay? So as you can see here, this scoliosis image, we've got some scoliosis in the thoracic cavity, and that scoliosis in the thoracic cavity is also causing a little bit of bend within the lumbar cavity. So keep in mind as we go along here that this side is the convex side, this side is the concave. So this side is convex, this side is concave, okay? So scoliosis radiography demonstrates the amount of degree of curvature that occurs with force acting on the body. So we're going to do them in an erect position, okay? So that allows gravity and just weight of that the patient carries the entire day on the spine. So it's used to evaluate fixation devices sometimes, as such as Harrington rods that are put in to correct scoliosis, and then bending studies are used to differentiate between a primary and a compensatory curve. Okay, so that's what the bending images are for. So we have our vertebral column, and we've talked about that. So we have the cervical vertebrae, there's 7 of them. The thoracic vertebrae, there's 12. Lumbar vertebrae, there's 5. Then we have sacrum and coccyx. There's different numbers here because when the sacrum fuses together, you end up with 1 sacrum. When the coccyx fuses together, you end up with 1. So a child usually has about 33 separate vertebrae, and an adult, after they fuse, has 26 within the vertebral column. So anatomy of the vertebral column, it has 4 curves, which we've talked about. So this convexes anteriorly. So what they're talking about here is this is the convex side, this is the concave side. So the arch anteriorly and posteriorly for mid-coronal plane. So lordotic curves are convex anteriorly. So when you're talking about lordotic, it's the convex towards the anterior side. So this is anterior and this is posterior. So lordotic, your lordotic curvature is the convex towards the anterior side. Okay, so lordotic anterior side. Your kyphotic curves are concave anteriorly. So concaved here, so anteriorly, that is a kyphotic curve. And then this one here is concave. So concave is pointing anteriorly. And then here, again, for a kyphotic curve that is concave anteriorly. Okay, so something to keep in mind is that they may ask you questions as far as we're looking at this in a lateral position. So what you want to make sure is you know what these curves are if you are looking at the patient in an AP position. So if I look at a patient in an AP position, the thoracic is convex, or the cervical, sorry. So if I'm looking at the patient AP, the cervical is convex. If I'm looking at the thoracic is concave in an AP position, and the lordotic is convex in an AP position. So looking AP at them, keep that in mind. Also, you can look at it if you're looking at a person in a PA position, okay? So a PA position, if I'm looking at the back of the patient when I look at them, in a PA position, my cervical spine is now concave. My thoracic spine is now convex. My lumbar spine is concave. My sacrum is convex. Okay? So keep that in mind so you know how to talk about it from the lateral, from the AP, and from the PA. Okay? So, anatomy of the vertebral column for scoliosis, it's a condition of abnormal lateral curvature of the spine. So we expect the spine to be straight, and when we get an abnormal curvature laterally, that's when we start getting scoliosis. So kyphosis is a condition of increased kyphotic curve of the thoracic spine. So what we need to pay attention to is what curve are we talking about? So we're talking about this convex curve here, and the sharper it becomes, the more kyphotic the patient curve becomes. So lordosis in the lumbar spine, the more concave that becomes, the more lordotic of a position the patient is in. So it's more lordosis, the more concave it becomes. So it's a condition of increased curvature of the lumbar spine. So lumbar for lordosis and thoracic for kyphosis. Okay? So slight lateral curvature sometimes presents in the upper thoracic region. Curves to the right in right-handed people, and then it also curves to the left in left-handed people. So a lot of times that curve is going to depend on if you're right-hand dominant or left-hand dominant. Lateral curvature is believed to be the result of muscle action and possibly influenced by occupation. So, which is kind of comical because usually scoliosis happens more in younger people. So I'm kind of wondering what occupation they may have as younger adults that they may be causing some of their scoliosis. Sometimes you'll see scoliosis in athletic individuals, and that could result from muscle action. So typically, if you see scoliosis, if it's curving to the right, that person's probably right-handed. If it's curving to the left, that person's probably left-handed. So scoliosis is an abnormal lateral curvature. So you have a usual vertebral column, and then you have what's considered normal, where there's a little bit of a slight curve. Nothing to really worry about. They'll keep an eye on it. But when you have an abnormal curvature, okay, that's when you have scoliosis. This may require some operative work, some Harrington rods in there to correct this scoliosis curvature. So some terms we're going to look at scoliosis. We have dextroscoliosis, which is a curve to the right, okay? Levoscoliosis, which is a curve to the left. And then if you have a curve to the right or left, but you have a rotation within the lumbar spine or within the spinal column itself, the vertebral column itself, then you can have rotoscoliosis. So that also takes into account the rotation with a lateral curvature. So you may have, say, levoscoliosis with some rotoscoliosis. So you're going to have a curve to the left with some rotation. Or you'll have dextroscoliosis with radioscoliosis. So you're going to have a curve to the right with some abnormal rotation. So just some terms to remember, some terms to write down and review every now and then about scoliosis. So scoliosis radiography, you're going to have, it's usually, depending on the system that you have, and now that we're moving to digital, most of the digital systems are going to take about 3 pictures, and the tube and the um, wall buck you're going to move at the same time, and you're going to take 3 pictures, and then you're going to it's going to stitch it all together for a complete image from say C1 or a little bit above down to your greater trochanters, your entire vertebral column. And a lot of times they'll only do an AP or PA. They don't necessarily do laterals. Your laterals will usually be done later on, say if the patient is going to go have surgery, or they've been had imaging done and they do have scoliosis, and they may need that lateral just to continue to watch maybe some rotation or to check to make sure that it's not getting worse. Okay, so before they had longer IRs, and then they would do, say, a 72-inch SID. So they would take an upper and a lower on the long IR. So it's not necessarily a 14 by 17. It could be, say, a 14 by 36 or so. But that takes special equipment to run those images. So some protection that can be done. You can image the patient PA instead of AP. You can add breast shielding either on the patient or collimator shielding on the collimation. Possible thyroid shielding depending. A lot of times a thyroid shield is going to, you're not going to see your C-spine. But if they've already had imaging and they know that the scoliosis is in the, say, T-spine or L-spine, they may put a thyroid shield on just to protect the patient. And then gonadal shielding sometimes is used more for female patients. And then you can always make sure that you put a really low wraparound gonadal shield for a male patient. You can shield. Shielding a lot of times isn't done anymore. So just know the protocol at your hospital. So they're showing here a PA and lateral. So the patient is in a true PA position. They're not rotated one side or the other. The arms are out of the way. The chin is up, and their feet are about shoulder width apart. You want to make sure that the feet are in proper position. So you want them in anatomical position. You don't want their feet up there and then have a patient with either pigeon-toed or duck-footed. So make sure that you check their feet out. You always want to image this without their shoes on. So they're standing on their feet. And then this lateral, you're just making sure that the arms are up out of the way. You can see the gonadal shield here. Once again, the feet are going to be shoulder width apart, and the feet are going to be properly positioned in an anatomical position. So you don't want their feet to point out or point too far in. You need to move their feet so they're in proper position, okay? So this is talking about shield on the collimator, and you can see the shield on the collimator. This is it that they're showing right here, that images like this. So that's gonadal shielding. And then these shields on the collimator right here can be positioned in or out. So that's what these are here, protecting breast tissue. Sorry, that line went across there. And then this one here on the lateral. Okay, so you don't often see this anymore as far as shield that goes on a collimator, but it's something just to keep in mind that it was used. It may come back, it may not come back. And then depending on what the protocol is, they may not use gonadal shielding on female patients. So you're always going to want to make sure that you try to do them PA and protect the breast tissue and the thyroid as well. So a scoliosis series, your basic series, AP or PA, erect, and then your erect lateral. Like I said, a lot of people are just doing AP or PA erect. The lateral is going to be something that, depending on clinic site or protocol, may not be done. A special AP or PA Ferguson method, which we'll talk about, AP or PA right and left bending, and then lateral hyperflexion and hyperextension. Okay, so those are the specials. So PA thoracolumbar is patient position upright facing the vertical bucky. So part position, you're ensuring the mid-coronal plane is parallel to the bucky, and the arms are abducted and not in the field. So you want to move the arms away from the body. Your central ray is perpendicular to the bucky, so there's no angle. Okay? So your scoliosis, thoracic, and lumbar vertebrae to include about 1 inch of the iliac crest, and then your vertebral column is in the center of the image. Okay, so proper centering. So the scoliosis that they're talking about here, they're not so much worried about the C-spine. It's just thoracic and lumbar. But depending on where you're at and their protocol, they may want to include as much of the cervical spine as possible. So watch your patient position of their head and their jaw to make sure that you're imaging as much of the C-spine as possible, that the chin isn't dropped down and it's not superimposing that cervical spine. Okay? So this is just a chart of APPA as far as KV, mass, breast tissue that they're saying in an AP position, you have higher radiation to the breast tissue than a PA position. So female patients try to do them in a PA. Male patients, they're usually placed AP. Okay, so lower image receptor border 1 to 2 inches below the iliac crest. So keep in mind that if you're doing these on individual cassettes, basically you're imaging a T-spine AP and an L-spine AP, then a T-spine lateral and an L-spine lateral. Otherwise, you're going to have a device on your equipment that's going to allow for stitching together of that image, and you're going to get a complete image, say head to about your greater trochanter as far as the entire image stitched together and sent over. So scoliosis, the lateral thoracolumbar image, your patient position is upright in a lateral position. The mid-coronal is perpendicular to the bucky. The arms are at a right angle. So your patient is standing here, and then the arms are up, usually holding on to the bar, so they're up and out of the way. Okay, so your central ray, once again, perpendicular. There's no angle on it, so it's a 0 degree. So your criteria for your erect PA or AP, your thoracolumbar lumbar spine is demonstrated. So you want all of the T-spine and L-spine. So here you can see you've got some C, but all of the T-spine, all of the L-spine, 1 to 2 inches of the iliac crest demonstrated, which you can see your iliac crest here. To me, the shielding is a little bit of the sacrum and maybe some of the lumbar. But you just want to be cognitive of where are the shadows and what kind of shielding are you going to be using. So optimal exposure factors. This is a 14 by 17 image receptor. So 14 by 17 image receptor, you're not getting all of your T-spine. This is a 14 by 36, which allows you to image the entire T-spine and L-spine on one image, okay? So keep that in mind. Erect lateral position scoliosis series, so true lateral. The lower border of the IR about 1 to 2 inches below the iliac crest, okay? And this is if you're, say you have that 14 by 36 for one image. Otherwise, you're going to be taking a T-spine and an L-spine, making sure that you have overlap of the T and L spine. Your criteria of the erect lateral, you want the thoracolumbar spine demonstrated, 1 to 2 inches of the iliac crest demonstrated, optimal exposure factors. You can see that this is with a breast shield right here. So make sure that that breast shield doesn't come into your T or L spine. Okay, so this here is, it doesn't have all your T and L spine. You're clipping a little bit, so this is probably a smaller cassette than what you've got over here. So this could be something that's going to have to be imaged as far as the T-spine and then the L-spine to get everything. So the Ferguson method, the first radiograph is taken in the same manner as the previous described PA. And then the second PA radiograph taken with patient's convex side, okay, elevated 3 to 4 inches. So the Ferguson method is with elevation of the convex side. It's specified that the elevation must be sufficient to require the patient to expend effort to maintain the position. Okay, so when you take the image and you have this patient and say they curve like that, so you have thoracic with the convex side. This convex side, that's where you're putting this block for them to place their foot on, and then this foot is going to be on the floor. Okay, so they have to expend effort. It's not comfortable for them to maintain that position. Okay, so you're elevating this in hopes of seeing if this will push back over. Okay. So the Ferguson Method-Scoliosis series, you can see the block down here that the patient is standing on. And if you're in a clinic that's going to do this, they're going to have some blocks that are either 1 inch thick, so you're going to stack 2 or 3 or 4 of them, depending on your patient. But you're going to take your first image, you can see down here, the first image has no block. The patient is in an anatomical position with both feet flat on the floor. And then when you take that picture, you're going to see which side has the convex side, okay, of the imaging. So that's where you place that block. That block goes on the convex side. So that would lift that side of the patient, and they have to expend effort as far as bringing this leg up and this leg down on the floor. So you want them to stand there in an anatomical position, not bending their knees, but expending a little bit of effort to keep that position. So criteria for the Ferguson method, the thoracolumbar spine is demonstrated. The vertebral column is in the center. You can see the breast tissue shielding here. And then a good 1 inch of the iliac crest demonstrated. So you're seeing some of the iliac crest and all of the L, most of the T spine. Okay, so your spine comes down. You have convex over here. So if this was a PA, this is the, so if it was imaged PA, this is the left, this is the right. So you're going to put that block under the right leg. Okay, this crest here sits lower than this crest. So by putting the block under here, you're raising that crest up. You're trying to force this convex to become more straight. So you're looking at your image. Where's the convex side? What side do I need to place the block under to raise that side? Okay. So scoliosis, this one here you can see is really, really bad. So you've got, basically you've got some convex here, you've got some convex here, but you can tell just by looking at the the iliac crest. This crest is really high, this one is down here. So the block is going to be placed right here. So they're saying here the left hip is elevated, and here they're saying the right hip is elevated. So if this was a patient, they elevated both right and left. They're just kind of showing you what's going on. But it might be one of those things that you're going to do a regular PA, and then you may do right hip elevated, left hip elevated. They're just showing you what's going on when you elevate the left hip. So this left hip comes up higher, and this right hip comes up higher. Okay? So AP right and left bending series. So this is erect, and you are bending to the right, and you are bending to the left. If you do it on the table, you're just going to have the patient hold the position best they can, and you're just going to move the shoulders, the upper torso to the right, to the left for that image, okay? Your criteria is the vertebral column centered, so it is centered as much as possible. This is in the center, and with the bend, you know it's going to come over here and off over here. So you have the crest demonstrated, an inch or so of the iliac crest demonstrated, and then you have the bending to the left and then bending to the right. So your lateral spinal fusion series hyperflexion or hyperextension. Okay, so hyperflexion, they're just going to curl into like a fetal position, and then hyperflexion, you're just going to ask them to flex their body or extend their body as much as possible. So flexion here, face flexion, they are curling into a fetal position, and then hyperextension, they're extending their thoracic spine back as much as possible and their lumbar spine back as much as possible, centering them and then making that exposure. So your criteria for hyperflexion and extension, so this is your flexion image, and then this is your extension image. So curling into the fetal position, you're looking at the vertebral bodies and the intervertebral disc spaces. Are they closing up? Do they remain open? And then the same thing here. For the hyperextension, you're looking at the vertebral bodies, the intervertebral disc spaces. How much do they open? How much motion does that range of motion does that patient have? Does this spine stay straight, or are they able to extend it back? Okay. So that brings us to the end of our scoliosis series. If you have any questions, please feel free to reach out to me, and I will get back to you with an answer.